I didn't realize, I had not worked with health play specialists very much, and I didn't really quite understand how useful they are, but they are very useful. And despite the test being not painful, as we saw before, a lot of our children have been exposed to trauma, whether it be through enemas, suppositories, having NG tubes because of clean prep. So I don't want to cause them more trauma, A, because my reading will be very messy on the screen, and B, because the children will not become compliant. So to date, 28% of my patients have needed this support, and sometimes they need support before, during, or after the test. And as you can see, it's mainly the younger groups here that need that support. So obviously, these numbers are not as, they've decreased the last couple of months because of coronavirus, but to date, we have seen 255 children who have had this test done. Most of them have done this awake, as you can see, and only 24% under GA. And those who have done it under GA is because they've come in for manual evacuation or Botox. It's very interesting to look at their sphincters before we inject Botox, or they have severe autism or learning difficulties, and it will be impossible to do it awake. I've seen a range of ages, as you can see, and what's really interesting, almost a third of my patients have some element of learning difficulties, autism, Down, or Asperger's. The proportion of my patients are functional, as you can see here, so that's the main ones I see, and a small portion of the organic causes. And what's really interesting to see is that a lot of these patients have been suffering for at least 7 years with this condition. So it's the chronicity that does concern me at this stage. Of course, everyone takes history very similar. The areas that I focus on, obviously, when they pass meconium, the toilet training, the age, and if they had any difficulty, stool consistency and frequency. Quite often I see patients who are taking the wrong medication or too much medication, and I can see that from their consistency. If they have any fecal or urinary incontinence, abdominal pain or PR pain, withholding, which is so common in our kids, straining on defecation, medication compliance, which is a big issue, and toilet routine. So looking at our data, we found that patients significantly improved in their stool consistency with medication. Bowel motion remained variable, but the majority of patients are going to the toilet daily or at least twice a week. Abdominal pain seems to be the main symptom that they're suffering a great deal with, and this is happening almost every day or usually. And also what's interesting, a third of our patients are also urinary incontinent, which I think is something that we need to work on and look a bit more into. So moving on now to some images of high resolution manometry. I don't know how much, so I'm sorry if this is too basic or too much information, but I'll do the best I can to explain what I see often every day. So basically, I remember once a consultant said to me that high resolution manometry is just lovely pictures, looks very pretty, and that's all it means to them. And I was trained in traditional, so these very simple lines, physiology, and when I first looked at these pictures, I didn't know what I was looking at. But it has an increased number of pressure sensors, which are closely placed longitudinally, so you can capture the anorectum greatly. As you can see, the cooler colors are light blue and green, which are low pressures, and the warmer colors are yellow, red, orange, and purple, which are higher pressures. So it does aim to get a better visualization and assessment of the sphincter complex, and I think we get better understanding of the pressure profiles involved. It does determine underlying pathophysiological mechanisms, it guides management, it does provide recognized disease-related phenotypes capable of predicting clinical benefit. So I think it's very, very useful. This is what my clinical room looks like. It's nighttime here, as you can see, and it's a very simple setup. It was Christmas time here, and it's very spacious, so the more space you have, the better for the child to feel comfortable. One thing I want to mention is that the catheter itself is not very large. I avoid I learned very quickly not to use words like catheter or long tube or balloon, because the children tend to get very scared. I always say to the parents or to the clinicians who are worried about it that it's simple. It's not like it's just as small as a suppository or a finger examination, a PI examination, or thermometer. So it's not invasive. It's not something that they should have been exposed to something like this before. So this is my protocol, and I can't take credit for it entirely. I actually used the adult protocol from the London team, but I had to modify it for pediatrics. And I'll go through this protocol slowly when I show you the images, but these are the different maneuvers that we ask the patients to do, with emphasis obviously on rectal sensation as well. I'm not going to go into great detail, but these are the physiological parameters assessed, and this is what's found in the paper that we published. And this gives you a bit of guideline of how we defined our maneuvers. And we do actually do all these maneuvers in every patient when they're awake. So this is what we see in high resolution anorectal manometry. This is the atmospheric pressure, so the outside world. Catheter goes in. This beautiful bit here is the anorectum, and we've got the rectal pressure here. So this is what we see, and this is basically pressure versus time, and you've got the colors there to help you as well. This is what it looks like when you capture the whole thing, which I'll go into individually. These are the maneuvers that I perform. And I do follow the protocol religiously, but I also sometimes have to bend the rules to make sure that I've got the images that I need. So one of the things I always stress to anyone starting high resolution manometry is, particularly something that you can see more with high resolution, is do not start recording or start measuring things at the beginning. You know, anyone of any age, when they have a catheter in the rectum, will get very, oh, this is not great. This is, you know, they'll squeeze the external anal sphincter. They feel uncomfortable. So you need to spend at least 3 to 5 minutes waiting for it to come to this beautiful green area here, which is the resting pressure. This is not always possible in pediatrics, as you can imagine, but I try very hard to relax the child. If it takes 3 or 5 minutes, sometimes it's taken longer, that's fine, until it's stabilized. Resting pressure. So as we know, resting pressure is controlled by the internal anal sphincter. This is a very beautiful normal resting pressure where you've got green, it's not too blue, and here you can get the numbers that you need for your results. In our patients, we don't have normative data, so that's my next project, to create normative data in London. And it's very important that if you use other people's normal values, you use the same setup, same program, same catheter, everything. So I've used the adult normal values, which of course is not scientifically perfect, but it's better than using something that is pediatric and not the right equipment. So we had resting pressure of 56.7 in our cohort of patients. We didn't find any correlation with sex or age. This one here, you can see it's much lighter, it's almost non-existent, and this patient here has a very low resting pressure. You can see here a mean of 20. And these are the patients really that I see who have anorectal malformation mainly, and that I guess we expect based on their anatomy and also their physiology after surgery as well. Squeeze pressure, oh sorry, before going to squeeze pressure, this is a very interesting patient. You see what's called here ultra slow waves, where you see regular pressure peaks. So if you see this, it's not the patient being distressed, it's actually, these are the physiological response to an involuntary squeeze. And these patients may benefit for things like Botox as well. But when you do see this and you see it happening every so often, every couple of seconds, if you time it, you can time it between these two waves here. You can see this is an involuntary squeeze. So squeeze pressure, the external anal sphincter. So this is an example where you get the patient to rest and then ask them to squeeze. And you can see a beautiful squeeze here in this patient. We have a mean of 107 in our cohort. We found, quite interestingly, that males tend to have a higher squeeze pressure mean compared to females. I'm not sure why as yet, but this is what we found so far. And this is a patient here who is trying very hard to squeeze, but the squeeze is very poor. And again, this is an anorectal malformation patient, so it's very you can see the difference quite easily. So this table here simply shows you the results of what I've just discussed, looking at the 255 patients, and I think this is just sphincter function in itself. So it's very useful to use when looking at the pathophysiology. This is the endurance squeeze that I mentioned before. I think this is very important. And people say, how long do you ask them to do it for? And to be honest, there's no science behind this. In adults, they use 30 seconds. So I just halve it to 15 seconds for children. And most children can do that absolutely fine. So this patient here has a good squeeze and can hold on for 15 seconds. This patient here, you can see, just squeezed once and really struggling to hold on. And that could explain that they might have normal sphincter function, but it might be a behavioral element. They're unable to squeeze on when they have that urge to defecate. The cough reflex, very important parameter to assess for involuntary function of the external anal sphincter. And basically the anal pressure should exceed rectal pressure. And any abnormal response, as you see here, may indicate any neural damage to the sacrum. So this is a patient here which is normal cough, and you can see here a patient that's not so normal. And if you can't get the child to cough, ask them to laugh, anything that's going to trigger the involuntary response. I'm sure you're all aware of the RAIR. You know, obviously I was trained with this traditional method a long time ago, and I find it easier. I've kind of got used to high resolution, but I found it easier to look at this screen more than the high resolution. But what you can see is the inflation here of the balloon, and you get that little curve of relaxation there. Point of maximal relaxation and the recovery curve just there. So you can see it beautifully on the high resolution as well. It's just getting used to the old-fashioned way to the new way. So this is a very interesting, so obviously this is a Hirschman's patient who has the inability to relax, and it's just constant contraction of the sphincter. And this is what we see in a typical Hirschman's patients. I have to say, I don't get many patients who haven't been diagnosed with Hirschman's before I see them, but there have been a few cases where I'll be, like today I had to go to theatre and there's suspicions of it, and they asked me to do physiology, and then we'll do a biopsy and see if they do have Hirschman's. This patient here, this can be very confusing, and it's something I want to explore a bit more. This patient has got a RAIR, but it's taking a much longer time to recover. And I find this in patients with chronic constipation. And something I want to look into more scientifically, and I have seen this a few times now in my cohort. Defecation maneuvers is something I haven't, I'm working on at the moment to go through all my patients. I think performing this in every patient is very important. We ask the patient to push or to bear down, and of course you get things like anismus or dyssynergia. And basically what you want to see is a good rectal propulsion with a significant increase in anal pressure. Rayo has explored this area very much so. His papers are very interesting, and obviously I've used his classifications for types 1, 2, 3 and 4 dyssynergia. And you can see here my patients, real life patients, are the different types of dyssynergia. So you've got the type 1, we get the adequate increase in rectal pressure but increase in anal pressure. You've got the type 2, as you can see here, where you have an inadequate increase in rectal pressure, which you can see over here, and also an increase in anal pressure, and also type 3 and 4. And type 4, you can see, is almost non-existent there as well. So I think one of the things that I found that the literature is lacking a lot of is the rectal sensation. There's been some excuse me, some studies on compliance, but rectal sensation has to be done awake, obviously, and so there isn't much literature on that. So the patient can have a normal sensation, whereby we put the catheter into the anorectum and inflate it 1 ml per second. These are the normal values that we use. Obviously, we are, it is subjective sometimes because we are dealing with pediatrics rather than adults. So you can have a child who's hypersensitive, And this is very much associated with urge fecal incontinence, patients with